treatment to 2 patients. One of them is actually my priest, Father Fausto, who's 90 years old. He has arthritis in both knees. But before I inject anybody, I do a thorough exam, and I want to have an MRI and x-rays. So today we're going to preliminarily set him up for an alpha-2 macroglobulin injection in the future. The patient that we're actually going to inject today is one of the world authorities on colorectal surgery, Gustavo Plasencia. Dr. Plasencia is from Miami, from Jackson South. He's actually been a friend of mine for over 40 years. He has a knee problem that he developed years ago from running, but for the last year or so, it's been very excruciating. Dr. Plasencia, can you point to where you're having this knee pain?
Right here, the medial aspect of the knee, there is a specific area right there that, right there, is likely where.
After reviewing his MRI and examining him, I think there's 2 sites, and they're probably intertwined. The lateral attachment of the meniscus, as well as the medial collateral ligament. So we'll be injecting in the knee and along the medial collateral ligament. Now, what is alpha-2 macroglobulin? Alpha-2 macroglobulin, we found at Stanford University probably over 20 years ago. We were looking at knee problems. We were looking at back problems, arthritis, disc disease, and we found 2 things. One, a lot of people have asymptomatic tears in the meniscus. A lot of people have herniated discs and have no symptoms. We know that 30% of the population by age 30 has a herniated disc without pain. So what determines if you're painful or not? The people with pain we found in our studies are positive for this protein, fibronectin aggregan complex. If that complex forms and you have a meniscal tear, and you have a rotator cuff tear, and you have a herniated disc, then this describes somebody who's most likely symptomatic from that musculoskeletal lesion. So we found that you had to have this present. If you treat people that are positive for fibronectin aggregan, you've got about a 90% chance of a response rate. And what we found was that what could destroy that complex was alpha-2 macroglobulin. Alpha-2 macroglobulin is a component of PRP, but we didn't find out that any of the other isolated proteins had a positive effect. Our lab found that there's actually over 650 proteins in PRP. Some of those proteins are actually bad, like the interleukins. So interleukins, we know, especially interleukin 6, is responsible for osteoarthritis. So those proteins that can cause inflammation, you have to get them out of the PRP. PRP has a bunch of proteins called interleukins, disintegrins, matrix metalloproteases, cytokines, and this protein, which is the largest protein, alpha-2 macroglobulin. At Brown, unbeknownst to us, Brown was researching this same protein, alpha-2 macroglobulin, and found that that protein was the master inhibitor. In one of their papers, Lee Wei, the head of the cartilage lab there, said that alpha-2 macroglobulin was the master inhibitor of cartilage breakdown. In another paper, he called it the strongest anti-inflammatory agent that we've discovered. So you'll find that this is what we use. This is what we're going to be using today in the injection. So we have to get the PRP, and then we have a second process where we have to filter the PRP through a pump to dilute out the other 649 proteins and concentrate the one called alpha-2 macroglobulin. And I've been using this for probably 18 years in the spine, intradiscal injections into the joints, the shoulder, the knee, the hip, the ankle, with very, very positive results. So this is what we're going to be doing today. Let me take you over to the filtering process, because to obtain this, is a two-step process, which makes it more expensive, unfortunately. So first we filter it, just like you filter PRP. We put it through a centrifuge. And that's done at 5,000 revolutions per minute for about 10 minutes. Once we get the PRP, we then have to draw it off. We draw it out of the syringes. This is what it looks like. We've already drawn it off here. You see the red cells, and you see this is what's called the buffy coat. There is a little bit of plasma left in the tube. Normally the tube was filled up to here after the centrifugation process. So we drew all the plasma off, and now we put it through here, and we put it through this filtering process where it's pumped through this patented filtration process, and the 649 proteins that we don't want end up in this bag. The alpha-2 macroglobulin ends up in this bag, and that's what we're going to be giving Dr. Plasencia today. Having some chronic knee pain here. It seems to be both at the joint line medially of the left knee and a little bit below, so over the MCL complex. So I've looked at the MRI. I think there's a little bit of fraying peripherally, where the meniscus attaches peripherally. About 10 years ago or so, he did have arthroscopic surgery to trim down the meniscal tear that he had on this side, but he was pain-free until about a year ago. So today we're going to be injecting these two areas, and I'll give him some in the suprapatella area over here. Well, for the anesthetic to work. And in the middle of this, you know who pops in? Is Hoist Gracie. Unbelievable. This is Dr. Plasencia.
How are you doing? Good, good.
No, we gotta get his family. We gotta get his. First of all, you need to meet him because we all need screening, colonoscopy. This is the #1 guy in the world. And the other thing is, he needs you because he has wonderful family and nephews that want to train in jiu-jitsu. So we have to put everything together. In any event, we've injected him. We've taken the proper amount of time. Now, one of the things that I do that I don't see being done is you have to drain. You have to try to drain the knee. So first we're going to transfer the good stuff here. We have the alpha-2 macroglobulin in here. We are now going to make the exchange, the transfer.
What did he have?
And the first thing we have to do is close off this. So we're going to close this off. And now we can draw the A2M up. Oh, we got a good amount of A2M. So it's not like we have just a little bit. We have a lot to give this young man.
What did he have?
He has a meniscal injury. So we drew it off as blood this morning, earlier, and now we have a lot. We have more than we need. We're going to try to give him all of that. First thing I do is I test the sites. Is that numb?
Yep.
Doesn't look like he feels it. How about this? Is this numb up here? Doesn't seem to feel that. So the first thing we do is we want to draw off and look. You see, a lot of times people say there's no fluid, but we've got fluid in there. We've got fluid. So we want to draw that off first. It's important to get rid of that fluid before we inject. And a lot of times this is a mistake that people make, is they don't draw the fluid off. Okay, so we've done that. We've got the fluid drawn off. Now, we can inject the good stuff. So first you must draw off the fluid before you can attempt to inject in the good stuff. And now we're going to inject in the good stuff. So we seem to have a really good injection in there. And now we come around to the other side, and we want some more injected right in there. And I might use a little bit more of the Novocaine, the lidocaine. Do you feel that?
Good.
A little bit? Okay, we'll let that take effect. While we're letting that take effect, we are going to inject along the medial collateral ligament where we found that he was painful before.